global pandemic experience has very quickly pushed us into greater use of precision public health, to the point where I believe that the general public is going to expect greater precision and greater performance, even if they can't actually name the concept of precision public health.
The COVID pandemic over this past year has given us an unprecedented opportunity to accelerate some of these infrastructural changes, but also showed us the schisms that lie between medical care and population health management in so many parts of the world. And so to focus on one small area that the team worked on this past year, we had focused on this idea of having a digitally connected diagnostic to better inform individual management as well as population management. And so in a very, very simple way, we thought about ways of testing for, in this case, for SARS-CoV-2. And we think of the incentives or the reason that a person might present. And so certainly there is a patient care incentive. So approaching a health system, having traits of COVID, one should have tests that are done, and these should be high sensitivity, and getting a treatment potentially. There are, and these are not in a regulatory frame, the way that people have looked at testing, but we have been arguing for some time about the need to interrupt transmission. And so detecting those people who are most likely to transmit virus, rather than simply finding whether a person is positive molecularly with, say, virus on a sample from the nose or oropharynx. And this concept of transmission interruption has much more of a population feel than it does an individual feel. And so while somebody may have positivity on one form of test, if they are sequestered or potentially not doing other activities that may lead to, say, a super spreading event, then the transmission is very unlikely. And so we would worry less about that in terms of risk. And then, of course, there's the general sense of epidemiology. So being able to look at population risks and positivity and understand trends, especially as there are population relative reactions to the condition.
Obviously, when this started in early last year, it became very apparent that we had a real need for real-time data and intelligence, and this was going to be vital into the decisions that made by the government and public health units within New Zealand about how to manage the pandemic moving forward. This required new systems and data pipelines to be set up very quickly, under quite high pressure and very short timeframes, and it involved a number of groups working together for the integration of systems and services, and people that either not work together or certainly not at the pace that was required for this. So one of the main systems we have in New Zealand is EpiServe. EpiServe is a notifiable disease database that ESR hosts and develops on behalf of the Ministry of Health. And it collects a lot of notifiable disease information in real time. Some of this is through laboratory notification using HL7 messaging. So when a notifiable disease test is carried out and it's positive, they send instantly an electronic message to EpiServe. This can then be used by the public health units. Can I have the next slide, please? And they create a case from that, and they can collect additional clinical features and risk factors either by interviewing or follow up with the patient or clinicians. It also allows outbreak functionality, so common cases that we know are linked, we can link them under an outbreak and do follow up on that. It enables ESR to provide a lot of intel already around positive information for monthly, weekly, annual reporting, and feeds into some of our early warning systems. We have the early aberration reporting system called EARS, which we do use, that uses algorithms to flag anomalies, and we've got some development systems that we're working on that we're predominantly using Flu at the time. So we had really good information around positive infectious disease data and around COVID as well, but we didn't get the whole picture of testing within New Zealand. So we weren't getting negative results. We couldn't see that overall picture of what was happening around the testing in New Zealand. So we really decided we needed a clinical data repository to collect this information, COVID information. And so we approached Sysmex around their Eclair solution, which was a clinical data repository. We had it installed in early March 2020. We had it online, actually set up within 2 weeks, but within 4 weeks we managed to collect COVID data, COVID PCR results from all diagnostic labs through the countries. And most of these labs are delivering it in real time, so instantaneously from when the result was released from the lab, we had it. Some other labs, there's about a 10-minute lag, but there's only a few labs that that's happening with, that we're working with to move on to the connected health system that we use. So once this was done, though, we started getting really good that information in. The benefits of the system was realised, and it's grown. So the secret to all of this really was utilising standards. So in this case, I'm talking about HL7 2.4 we decided to use. We used LOINC coding to code the analytes, and also genomic CT coding around resulting. So how we did this was we established a working group that sat down and worked on what standards we were going to use and what our methods of delivery were going to be. The agreeing of these standards and coding steps was essential so that we were getting clean data in that we didn't have to do any extra work on. We also worked closely with the Ministry of Health on formalising this as a proper COVID-19 standard and publishing it on the website so that any lab could pick this up and know how to report to us. So, as I said, the data that we're collecting had a number of places it was used. It was used in the daily reporting of COVID-19 numbers for the Prime Minister and Minister of Health and our Director of Health at the daily stand-ups, and fed into the intelligence that the Ministry was gathering for their decision-making around how to handle the pandemic. So it was a key part of that. Also being passed to the National Contact Tracing System, so that if we had positive cases and we had close contacts were being followed up, they had the most recent up-to-date result information available to them. And obviously we had a public-facing dashboard, which is a static dashboard that gets updated once a day once the Ministry has announced the numbers for that day. We also have a private real-time dashboard that had a smaller audience of the Ministry of Health and public health units. We also feed into the data modelling teams around their elimination strategy work they were doing, and obviously, as I said before, our early warning system development. So what are our lessons learned? So developing systems and pipelines during a pandemic, and if at all possible, we would avoid it. It's quite stressful, lots of long hours worked by many people, not good for the waistline, not good for my disappearing hair. But that being said, it's amazing what you can get done in a crisis and how people can come together and work to provide these amazing systems that people have managed to set up. It requires continued investment and review and discussion is a must about the system. So looking at what we've got, seeing if we can improve it, making sure we're investing in people and infrastructure to support these new systems and foster the groups that we've created. Because these groups, we want to see, there's so much we can do with these groups outside of COVID. And that's the final point I want to make, is taking what we've developed and applying it to the wider population health surveillance systems and what we can do across the board. And we're looking at the moment, we're developing an Intel Hub, which will be a one-stop shop for notifiable disease in New Zealand, that we can see what's happening at any one time across the board.